Welcome to Season 4, Episode 20 of Workers Comp Unwrapped, with your host, Aneeq and Angela as our guest. Today we are talking about coordinating multiple providers without triggering denials, where we are focusing on reduce risk in co-managed care scenarios by avoiding overlapping codes and treatments.
It is quite the minefield out there right now.
Oh, it's an absolute mess.
Yeah.
I mean, if you are running a clinic or, if you practice medicine in the workers' comp space, logic dictates something pretty simple.
Right.
Having a comprehensive multidisciplinary team of specialists surrounding an injured patient is basically the gold standard.
Yeah, absolutely. It's just good medicine.
Right. You have all these distinct experts collaborating to, heal a human being. So naturally, you would assume the insurance payer would be absolutely thrilled.
You'd think they'd send you an edible arrangement or something.
Exactly, a fruit basket at least. But no. Instead, having multiple doctors on a single claim is treated by the payer software like you've just formed a cartel.
That is exactly how they see it.
I mean, the system views it as this vast, coordinated conspiracy to commit duplicate billing rather than, actual patient care.
Yeah, the medical community fully understands that a complex injury like, say, a really multifaceted lumbar spine trauma requires multifaceted care.
Right. It takes a village.
Exactly. But the moment the payer's claims processing system detects a physical therapist, a chiropractor, and maybe a pain specialist all touching the exact same claim,
the alarms start blaring.
The internal threat level basically goes to red. Because the algorithms scanning these claims, they're not programmed to recognize a comprehensive care team.
No, they don't care about your team.
Not at all. They're programmed strictly for risk mitigation. They just see billing multipliers. So their baseline programming automatically assumes the care is excessive or uncoordinated or medically unnecessary, unless you can aggressively prove otherwise.
It is pure bureaucratic paranoia. I mean, we know what the result is for you, the listener.
Right.
It's a minefield of costly denials, utilization review purgatory, and massive payment delays.
Oh, the delays are brutal.
But let's actually look at the mechanics of why these insurance systems default to such deep suspicion in this deep dive. Because if you lay out the sheer number of players involved in a standard co-managed claim,
it's a huge roster.
It's massive. You have the primary treating physician who is supposedly, the quarterback of the claim.
Right, the person calling the plays.
Yeah. But then you bring in the physical therapists, the chiropractors, pain management specialists.
An orthopedic surgeon, maybe?
Exactly. Maybe a clinical psychologist, occupational therapists. It is a massive roster of people all touching one file.
And it's a massive roster that is usually operating in total administrative darkness.
Oh, totally blind to each other.
Exactly. Each provider in that lineup is treating the patient, documenting their clinical findings, and billing the payer in complete isolation.
Right.
They exist in totally different clinics using entirely different electronic health record software. And honestly, they rarely even look at each other's notes.
Which is terrifying, honestly.
It is. And when we talk about how a payer system processes this, we really have to talk about the CMS 1500 form.
The dreaded billing form.
The one and only. The CMS 1500 form is entirely numerical. It takes all of that nuanced, highly specialized human care and just violently strips away the narrative context.
It boils a human being down to numbers.
Right. It translates someone's entire recovery journey into a handful of isolated 5-digit CPT codes and ICD-10 diagnosis pointers.
So it looks completely generic to a computer.
Exactly. So when those separate, totally uncoordinated CMS 1500 forms hit the insurer's desk, the algorithm doesn't see a beautiful team effort.
No, it sees a chaotic mess.
It sees overlapping codes hitting the exact same body part all at the same time.
It makes me think of like the chaotic group project, right?
Right.
It's like 5 different people are trying to steer a car at the exact same time, but nobody is talking to each other.
That's a great way to put it.
Or actually, it's less like steering a car and more like 5 different people trying to use the exact same barcode coupon at a self-checkout register.
Oh, I like that analogy.
Right. You've got the PT scanning a code for the back, the chiro scanning a code for the back, the pain specialist scanning a code for the back.
Beep, beep, beep.
Yeah. And the self-checkout register doesn't know why you're scanning it so many times. It doesn't know that each scan represents a slightly different service for the patient.
It just knows the rule.
Exactly. It just physically locks the system and starts flashing a red light because, hey, that coupon can only be redeemed once per transaction.
The self-checkout machine is the perfect way to look at it because, the machine totally lacks the capacity for clinical nuance.
Right. It's just a dumb terminal.
Right. And the system lockdown actually happens when two of those providers try to scan their codes during the exact same treatment window.
The ultimate collision.
Yeah. If we look at the data from our sources for this deep dive, the single biggest trigger for these automated denials is overlapping treatments on the exact same date of service.
Oh, man. If you are running a clinic right now, you know this specific pain point intimately. It is so frustrating.
It really is.
Let's walk through a 30-day timeline of, like, a classic showdown, the physical therapist versus the chiropractor.
A tale as old as time.
Right. So let's say a warehouse worker takes a massive fall, severely injuring his lower back. By day 14 of the claim, he is receiving physical therapy.
Makes sense.
But then by day 15, he is simultaneously seeing a chiropractor for those exact same musculoskeletal complaints.
And in a clinical setting, we know those are distinct therapies, right?
Right, they do different things.
Exactly. The physical therapist might be focusing entirely on therapeutic exercise to rebuild the core strength and stabilize the pelvis.
Yeah.
Meanwhile, the chiropractor is focused on spinal manipulation to ensure joint mobility. They actually complement each other beautifully.
Right, it's good care. But then day 30 rolls around.
Yep. On day 30, when the billing goes through the clearinghouse, the collision happens.
The self-checkout machine locks up.
Precisely. The physical therapist bills CPT code 97110 for therapeutic exercise. Then the chiropractor bills 98941 for the manipulation.
Okay, so far so good.
But perhaps the chiropractor also bills a code for neuromuscular re-education, or maybe an evaluation code that shares overlapping relative value units, or RVUs, with the PT's codes.
Ah, there it is, the overlap.
Yes. The payer's automated system scans this and just sees two different national provider identifier numbers billing for musculoskeletal rehabilitation on the lumbar spine at the exact same time.
So the algorithm just flags the overlapping RVUs as duplicate care?
Automatically. Boom. Denied.
But wait, I have to push back on this.
Yeah.
Because isn't it entirely bad faith for an insurer to deny a claim based purely on an algorithmic assumption?
Providers ask that all the time.
Right. I mean, shouldn't they manually review the clinical notes first before pulling the plug? Why are we blaming you, the clinics, for the fact that the insurance company uses lazy, overly aggressive software?
It feels incredibly unfair, I know.
If both the PT and the chiro did completely legitimate, necessary, distinct work, denying it outright just borders on a breach of contract, it sounds like the system is rigged to default to fraud.
The frustration is completely justified. I mean, it really is. But the reality of the system is driven by sheer volume.
Just too many claims.
Exactly. Payers are processing tens of thousands of claims every single hour. Manual review of every single clinical note is mathematically impossible for them.
I guess that makes sense administratively, but still.
Oh, it's awful for the provider. But the algorithms are built to flag statistical anomalies. When two providers bill overlapping RVUs for the same body part on the same day, that is a statistical anomaly in the broader healthcare data set.
So they just freeze it.
Yeah, and the burden of proof automatically shifts to the provider.
Wow.
Without ironclad, explicit documentation from both clinics that practically screams to the auditor, here's exactly how my specific treatment differs from the other provider's treatment, the system just defaults to protecting the insurer's capital.
It's a guilty until proven innocent model of reimbursement.
That is exactly what it is.
Unbelievable. So doing things that look the same to the algorithm causes a denial. But what happens when the providers actually disagree on the official record?
Oh, that's even worse.
Right. We're talking about a literal civil war in the patient's file.
This happens so frequently when there is no centralized communication. Let's take that same warehouse worker we were just talking about.
Okay, poor guy's still injured.
Still injured. Provider A, the orthopedic surgeon, evaluates the patient and dictates a very aggressive physical therapy plan to break through scar tissue.
Okay.
The clinical note explicitly says, push the patient hard, high-frequency therapy.
Guess what, clear enough.
But then provider B, the pain management specialist, sees the patient 3 days later. The patient complains of a severe flare-up.
Oh, boy. So the pain specialist pumps the brakes.
Exactly. The pain specialist documents the need for a highly conservative, reduced treatment frequency. The note says, patient unable to tolerate aggressive movement-reduced therapy to pain relief modalities only.
Oh, man. So now you have two highly educated specialists writing completely contradictory directives into the permanent, legally binding medical record of this workers' comp claim.
Yes. And when those contradictory notes hit the desk of a claims adjuster or are flagged for utilization review, everything stops.
The UR nightmare begins.
Right. Utilization review, or UR, exists strictly to determine medical necessity based on evidence.
Right.
When the treating doctors on the exact same case cannot even agree on what is medically necessary, the UR physician uses that conflict to question the credibility of the entire treatment strategy.
So they just toss the whole thing out.
Pretty much. Every single provider on that claim must independently support their own medical necessity. You cannot lean on the primary physician's notes if your own immediate findings don't match up.
Wait. If Dr. A says go hard and Dr. B says take it easy, the insurance company uses that confusion to just cancel the check for everyone?
Often, yes.
How is that fair to you, the listener, who is just trying to do your specific job? You could be executing your specific therapy flawlessly.
I know, it's agonizing for clinics.
But because the ortho and the pain doc are having a silent argument in the paperwork, the UR reviewer just throws up their hands and denies authorization for everyone.
Until the providers get their story straight, yes. Because think about it, the UR reviewer is not authorized to mediate a medical debate.
Right, they aren't the referee.
Exactly. Their mandate is just to ensure the insurer is only paying for clear, justified care. If the clinical paperwork is fighting a civil war with itself, the safest, most legally defensible action for the UR department is a blanket denial.
Which brings us to this bizarre psychological side effect of this whole system. Because doctors know that contradicting each other triggers these massive UR audits, right?
Right.
So they become terrified of writing anything definitive. They try to play it safe. And this leads to what our sources identify as the copy-paste trap.
Oh, the copy-paste trap is everywhere.
To avoid the civil war, they just write vague nothingness.
Yes. Providers are exhausted, They are seeing dozens of patients a day. And modern electronic health record systems make it incredibly easy to just duplicate previous entries.
It's just a single click.
Exactly. You open the file, click a button, and yesterday's note populates today's encounter. Visit after visit, you see the exact same phrasing.
Patient tolerated treatment well.
Yes. Patient tolerated treatment well, continue current plan. They do this thinking a neutral note won't trigger a red flag.
But to an algorithmic auditor, a static, copy-pasted note is blood in the water, isn't it?
Oh, it absolutely is.
Because it doesn't trigger the conflict algorithm, but it triggers the maintenance care algorithm instead.
Right. It is exactly the opposite of playing it safe. To survive algorithmic scrutiny in a multi-provider case, you must actively document the clinical evolution of the patient.
You have to tell a story.
Yes. The algorithm is looking for objective functional progress. Did the patient's lumbar flexion improve by 10 degrees this week? Document it.
Can they lift a 15-pound box from the floor to their waist, whereas last week they could only lift 5 pounds?
Exactly. Document it. If the clinical notes from week 1 look identical to the clinical notes from week 6, the software flags the claim under the assumption that maximum medical improvement has been reached.
Or that they're just milking the system.
Right, that the treatment has devolved into purely unpayable maintenance care.
Now, I hear billing departments talk about a workaround for this all the time. They say, just use modifier 59, slap a modifier 59 on the code to show it's a distinct procedural service, and it forces the system to pay it.
Oh boy. Let's explain how modifier 59 actually works, because it is wildly misunderstood.
It's not a magic wand, is it?
No, it's really not. Modifier 59 is a 2-digit code appended to a CPT code that essentially tells the payer's computer, I know this looks like a duplicate service, but I promise you it was a distinct, separate procedure performed on a different site or in a different session.
So it's basically a trust me button.
It used to be. Historically, it was used to bypass automated edits. But it is not a magic wand anymore.
Because the algorithm's adapted.
Right.
They know people use it as a cheat code.
Oh, they definitely know. Pair algorithms now track the specific frequency of modifier 59 usage per clinic, tied directly to your national provider identifier.
So they're building a profile on you.
Absolutely. If your clinic appends modifier 59 to, say, 30% of your claims, the software automatically flags your NPI for a comprehensive audit.
Wow.
And when human auditors pull those files and look past the billing modifier, what do they see?
They see the copy-pasted patient-tolerated treatment well template.
Exactly.
It's like putting lipstick on a pig. You've essentially painted a bullseye on your own claim.
Yes, you really have.
Used a modifier to tell the system you did something highly specific and distinct, but your narrative notes show absolute copy-pasted generic repetition.
Right. You are handing the auditor the exact ammunition they need to claw back the payment.
Man, So relying on billing modifiers without the dynamic clinical narrative to back them up, that just dramatically increases your audit risk over a 12-month cycle.
Without a doubt. The documentation must clearly and continuously define your specific evolving role in the patient's recovery.
You have to explain it.
You have to explain in writing how your treatment actively pushes the patient toward returning to work, independent of what the other providers are doing.
So the paperwork has to be flawless. But even if every clinic writes beautiful, dynamic, hyper-specific notes, what if the timeline of those notes is completely out of sync?
That's the other massive point of failure.
All right, we have to address the operational lag here. Because clinical storytelling is useless if the administrative coordination is operating on a, 3-week delay.
The administrative timeline is where the financial battle is actually won or lost in co-managed care.
How so?
Let's look at delayed communication between front offices. Suppose the primary treating physician evaluates the patient on a Tuesday and decides to completely alter the recovery plan.
Okay, shifting gears.
Right, maybe shifting from active strengthening to passive modalities because of a brand new MRI finding.
Okay.
But it takes the front office 3 weeks to fax that updated medical report to the physical therapist's clinic.
Oh, wow. So for those 3 weeks, the PT is treating the patient, charting the progress, and billing the clearinghouse based on a medical strategy that officially no longer exists.
Exactly. And when the insurer eventually audits that timeline, the disconnect is glaring.
Oh, I bet.
The primary physician's notes say stop active strengthening on the 1st of the month, but the PT's bills show active strengthening continuing until the 21st.
Which looks terrible on paper.
It looks completely medically unnecessary. Those out-of-sync services are prime targets for independent medical reviews and immediate clawbacks.
Because the insurer will just argue that the PT services provided during that 3-week window contradicted the primary physician's active orders.
Exactly.
So how do you fix that? I mean, how do you force these siloed, overwhelmed clinics to sync their timelines? If you are a practice manager drowning in this administrative chaos, how do you get everyone on the same page?
You really have to utilize case managers effectively.
The case managers?
Yes. When communication is breaking down, case managers act as the air traffic controllers of a complex workers' comp claim.
Air traffic controllers, I like that.
They are often the only humans in the loop whose sole job is to force the silos to communicate. They ensure that appointments are logically aligned, that treatment timelines make clinical sense,
and most importantly, that major provider updates are actually circulated to every single specialist involved in real time, not 3 weeks later.
Precisely. They physically push the updated roadmap onto everyone's desk before the next billing cycle hits.
That is huge.
It is. As we project into the healthcare landscape of 2026 and beyond, administrative and operational coordination is just as vital to getting paid as the actual clinical medicine.
Which is wild to think about.
But it's true. You can be the most talented orthopedic surgeon or the most effective therapist in the region, but if your front office staff isn't actively communicating with the other front offices on the case, your clinical excellence will not protect you from a devastating wave of billing denials.
Yeah, that's a hard pill to swallow. Let's summarize the harsh reality of this for everyone listening.
Good idea.
Whether you are the physician holding the scalpel, the biller fighting with the clearinghouse over overlapping RVUs, or, the practice manager just trying to keep the clinic's doors open, the core lesson is inescapable.
Completely inescapable.
Co-managed care only works financially when you actively define your specific role. You have to eliminate unintentional CPT overlap by knowing what the clinic down the street is doing.
Right, you have to talk to them.
And you must document a cohesive, constantly evolving recovery strategy. You just cannot operate as a lone wolf in the workers' comp space anymore.
You really can't. And the urgency here cannot be overstated, mainly because of the looming threat of advanced payer analytics.
Oh, right. The algorithms are getting smarter.
Much smarter. The algorithms we've discussed today, the ones checking for duplicate codes and copy-pasted notes, they are rudimentary compared to what payers are deploying for 2026.
Scary thought.
They are moving far beyond simple code matching. Payers are deploying machine learning systems that run pattern recognition across millions of claims simultaneously.
So they'll catch everything.
Everything. These new systems are incredibly adept at hunting down vague documentation, identifying questionable treatment duplication across entirely different medical networks, and tracking the exact frequency of your modifier usage.
Wow.
If you rely on outdated, isolated administrative habits, you are walking straight into a buzzsaw of automated, algorithmic denials.
Which brings me to a final, slightly terrifying but highly provocative thought for you to mull over.
But
We are watching insurance payer analytics evolve into these hyper-advanced, ruthless, automated gatekeepers.
They really are.
Their systems are denying thousands of dollars in human care based on overlapping relative value units and the faintest whiff of contradictory clinical notes.
Right.
So, are we rapidly approaching a future where you, the medical provider, will need to purchase and deploy your own advanced AI just to write a clinical note complex enough to appease their AI?
Fighting fire with fire.
Exactly. Are we heading toward a reality where human healing is just an inconvenient byproduct of two algorithms violently negotiating a billing code in the cloud?
It certainly feels like it sometimes.
Think about that the next time you hit copy and paste in your EHR. Thank you for joining us for this deep dive into the source material. We will see you next time. Thanks for listening to Workers Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patients' care.